affecting global health around the world, and it's on the Ebola outbreak. What we're going to do is look backwards on what happened during the outbreak and looking forward and how we need to address this outbreak and future outbreaks. We have two very exciting speakers today, and I'll introduce them shortly. But before I do that, let me tell you a little bit about the Consortium of Universities for Global Health. We are a consortium of over 114 academic institutions around the world, based in Washington, D.C., working across research, education, and service to deal with some of the compelling global health challenges we face. Please see our website at www.cugh.org for more information about the consortium, and please join our activities in addressing these challenges. So the outbreak that we were talking about today, the Ebola outbreak, has been one of the largest and perhaps arguably the most serious global health challenge facing the world. When a little child was infected back in December 2013 and died, it started a cascade that's resulted in a cataclysmic challenge and a catastrophe in West Africa. Over 20,000 people have been infected. Over 8,800 people have died. The world is ill-prepared to deal with this. Our first speaker, Professor Larry Gostin, is one of the global health leaders in this area. He is a professor and chair and founder of the O'Neill Institute of Global Health Law at Georgetown University. And he will tell you a little bit about the challenges that we have faced and some of the large systemic solutions that we have to impose and introduce to prevent future challenges from occurring. Rosa Cristani works with Médecins Sans Frontières. He's been the leader with the MSF outbreak team since July of 2014. She's going to bring a vital and very important view from the field, from what MSF has done, which has been absolutely outstanding to save lives in West Africa. She's going to let us know about what they saw from the ground, what went wrong, and what needs to be fixed, what they learned, and how we move forward to prevent future outbreaks. How this agenda is going to work is I'm going to introduce Professor Gostin now, who will speak shortly. Then Rosa Cristani will speak. Then we'll go in for a question and answer for about 20 to 30 minutes. I will repeat the question so you'll know what it is and direct it to one of our speakers who will respond to you. So without further ado, it's my pleasure to introduce Professor Larry Gostin, who is also a board member of CUGH and who is the chair of global health at the O'Neill Institute and a world leader in global health law. Professor Gostin, over to you.
Thank you very much, Keith and Rosa, and thank you for all of those who are online. My goal is really to demonstrate why Ebola is a pivotal moment for the global health system. And it's a pivotal moment that if we don't seize, I don't believe, we will lose the confidence of a generation in our ability to handle global health threats. And that's particularly true of the World Health Organization. What I envisage is a Ebola leading to a very much reformed global health system with the World Health Organization at its apex and strong health systems at its foundation. And what I'm going to do today is cover three broad areas. The first, I want to do a very short retrospective analysis. Secondly, I want to look at WHO reform. And then thirdly, I would like to examine what the lessons learned are for global health security and what we can do to prevent the next outbreak, which I think is preventable, not only of Ebola, but of many global health security threats. So first, let me look at with you at the retrospective, a very brief one because I don't have a lot of time. But I think, as we all know, the location of this outbreak could not possibly have been worse. It was in three post-conflict countries in West Africa, Sierra Leone, Guinea, and Liberia. They all had very fragile health systems a great distrust of government, and with good reason, low health literacy rates, and not just fragile health systems, but really health systems that even before the epidemic began were decimated in terms of human resources, doctors, nurses, community health workers, and others. And I think if it wasn't for MSF, we would have been in even bigger trouble than we were. This was also a place, a region of the world where there were unsafe burial practices, where individuals who were being buried were touched by survivors, and that transmitted the infection. And then the final reason why this couldn't have been a worse place is the novelty of Ebola in that region. West Africa had never seen an Ebola outbreak before, and this, I think, contributed to delays in recognizing the problem. As Keith said, Ebola first appeared in a 2-year-old child in December of 2013. Ghanaian health officials had misdiagnosed initial cases, with Guinea not confirming Ebola until March 21st, and Liberia 2 days later. In Sierra Leone, scientists had suspected Ebola, but the information hadn't reached surveillance teams, and Ebola was unconfirmed until late May. And these missed initial diagnoses contributed to a second wave of Ebola in Liberia in June, and that would later be linked to a funeral of a traditional healer in Guinea in March. The government's early actions seemed to be the wrong way to change behavior. Families hid their feverish individuals. The population was reluctant to follow safe burial practices. And in extreme cases, there was violence against health workers, educators, and police. The world's attention really to this emerging crisis did not appear to ramp up until a Spaniard was taken and airlifted, evacuated from the region with Ebola, and cases in the United States occurred. The U.S. cases got an experimental form of a therapy called ZMapp, which also added to the ethical concerns about why a northern high-income country individual got these kinds of drugs when others did not. It wasn't until August 8, 2014, that Margaret Chan, the Director General of the World Health Organization, declared a public health emergency of international concern. This was 4 months after the first international spread of the virus, and it was also fully a month after the president of MSF had urged the World Health Organization to declare a global health emergency. But with the evacuation of cases from the United States and then the entry of a case from Liberia to Dallas, Texas, the world's attention took hold. The United States, President Obama, on September 16th, announced the mobilization of military assets in Liberia to build treatment centers. 2 days later, the UN Security Council, in an unprecedented move, passed a resolution calling Ebola a threat to international peace and security. And the next day, the UN Secretary General Ban Ki-moon announced a UN mission for Ebola emergency response called UNMIR. All of these efforts seem to sidestep the World Health Organization and virtually sideline that organization during the height of the crisis before the WHO could find its footing. Right now, we're in a position where global health leaders like the World Health Organization, the World Bank, and others have a philosophy of getting to 0 cases. I'd like to hear Rosa's view about whether or not that's feasible, or whether or not we're going to see Ebola virus disease endemic in the area, which is what some people fear. So that is a very brief retrospective about Ebola. I now want to move to the World Health Organization. I'm going to suggest that there are 5 fundamental reforms in light of Ebola that the WHO must undertake. The Executive Board, as many of us know, in January of the WHO, did for the first time recognize some of the long understood deficiencies in WHO governance and finance, and have proposed a very good, not full and adequate, but a very good reform agenda. That agenda, I believe, is going to go to the World Health Assembly in May, but there won't be any confirmed reforms, I think, until the World Health Assembly in May 2016, at least from the discussions I had at WHO, and I've just returned from Geneva a couple of days ago. So the first reform is to ensure sustainable funding scalable to the needs of the WHO. And the World Health Assembly should double the WHO's overall budget, with mandatory dues comprising at least 50% within 5 years. The WHO's 2014 to 15 budget was a little bit less than $4 billion. And this is in comparison to a much larger budget, say, for the U.S. Centers for Disease Control and Prevention, and yet WHO is responsible for the entire global health system. And that is a huge problem because the resources available to WHO are incommensurate with its worldwide responsibilities, and its budget cuts just before the Ebola epidemic meant that its epidemic response unit was decimated and was left ill-prepared to engage as well as it could and should have been in West Africa. The other problem with financing of WHO is that only about 20% of WHO's budget is within its own control. 80% is controlled by other organizations, and these are the Gates Foundation, the United States, the European Union, Australia, and other countries. And what this means is that WHO can't set its own agenda, it can't set its own priorities, and I maintain that no organization can survive and be very effective if it only controls such a small amount of its budget. So I'd like to see its budget rise, and rise at least 50% of the funds being mandatory funds under WHO Secretariat's control. The second is that we need to reform WHO's regional structure and empower the Director General to appoint regional directors and speak with one voice. There was a lot of discussion about conflicts, or at least tensions, between headquarters in Geneva and AFRO, the African Office for the WHO. And the regional system needs reform so that they can speak with a single voice, act cohesively, and with a single-mindedness of purpose. The goal is to change the governance of WHO to harness the power of civil society. It seems to me that civil society can transform global health. They proved that during the AIDS epidemic, and I think that if we embrace and empower civil society rather than push them away, as WHO sometimes does, this would be a huge benefit for WHO, and I think, again, the role of MSF has been critical and was shown to be in West Africa. The fourth is to exert WHO's constitutional authority as a normative organization. And at the moment, it does control the international health regulations. And those international health regulations were the legal authority which Margaret Chan declared a public health emergency of international concern. The international health regulations themselves showed considerable weakness during the Ebola outbreak, particularly because the recommendations of WHO were completely discretionary and widely ignored on the ground. And then fifth is that we have to build health system capacities in lower and middle income countries. One of the things that the International Health Regulations, which is a global health treaty, requires is for countries to support capacity building of the health systems all over the world. But countries, lower income countries haven't done this, and certainly upper income countries have not contributed to health system capacities around the world. This needs to change. And now let me just pivot to the very final point, which is how do we prevent another disaster like this? Not only Ebola, but many other global health crises that will emerge in the future. I suggest that we need to build health systems and human resources, and we could do it in three ways. The first way is to create an emergency contingency fund, and I would like to see that fund at the World Health Organization. This fund should have been in place before Ebola began, because in 2011, WHO conducted an independent review of its performance under the international health regulations during the H1N1 pandemic. And that report, chaired by Harvey Feinberg, called for a standing contingency fund at the WHO to be unleashed and triggered by a global health emergency. WHO never adopted that, but it's back on the table at the executive board. I think there's now robust support for it, and I think it's absolutely critical that we have funding in place. It is simply untenable to wait until an emergency is upon our doorstep before we begin mobilizing funds. We have to do it in advance. The second idea is for a global health workforce reserve. Michelle Berry at Stanford University, another board member of CUGH, and I have proposed such a reserve workforce. This is a workforce of highly trained doctors, nurses, and community workers who could be mobilized in an emergency. One of the things that Ebola taught us was that the absence of skilled and adequate human resources can be devastating for recovery from a crisis. So this is the second thing that WHO needs to do. And then the third is an international health systems fund. This is something I proposed in the journal The Lancet, and it seems to me that beyond short-term thinking that Ebola, H1N1, or any other SARS and other crises have provoked, that always short-term thinking, and then once the crisis is over, we stop. What we need to do is learn and take a long view. And that long view would be to really build the underlying health systems in low and middle income countries. This would be very important for global health security in terms of surveillance, laboratory capacity, human resources, response capability, and the like. But it's also absolutely necessary for other diseases, for non-communicable diseases, cancer, heart disease, respiratory diseases, for injuries. It's necessary for well babies and safe births for mothers. I think it may be fair to say that during Ebola, more people died unnecessarily from other causes than Ebola because the health system was in such disarray. And so we need to build that international health system. So Ebola is a transformational moment in the global health system. I believe that if we don't take the kinds of actions that I've outlined and we don't take them with a sense of priority and urgency, that we will lose faith in the international community generally and the World Health Organization in particular for a generation. We can't let that happen. The WHO is too important, too critical for global health, not to empower it and transform the global health system to prevent the next health threat that will face the world. So I thank you, Keith. I thank CUGH and all of those who've come to listen to this webinar. And I'll now very gladly turn it over to Rosa.
Thank you very much, Professor Gostin, for your eloquent examination of not only what happened before and the problems faced when the crisis started, but importantly, your ongoing and eloquent discussions and your ongoing fight for those constructive solutions you mentioned to take this crisis and use it as a transformational opportunity to reform the global health architecture so we can not only respond to infectious diseases, but as you said, respond to the tsunami of non-communicable diseases that we're faced with. It is my great pleasure, and you'll all have a chance to ask Professor Gostin questions after Rosa finishes her comments. So we're delighted and really honored to have Rosa Cristani here as our next speaker. Rosa is a task force Ebola leader within Médecins Sans Frontières. Rosa has been extraordinarily busy. She has been managing the intervention for MSF since July 2014. So Rosa, really, we know you're extremely busy. Thank you very much for being here, and the floor is now yours.
Welcome, and thank you for everybody for the invitation. It was really interesting to hear Larry, and I think that our two speeches are a little bit complementary. Very general view, and now I will give a little bit of a field perspective. The presentation will go through one short part on Médecins Sans Frontières work since the beginning, but I will go very fast on this. It's not the main discussion here. And after a discussion where we are now, because Larry explained the background and the history of the beginning, I give a short update on where we are now with Ebola. It's not finished yet, and need to be clear. And later on lesson learned on what was wrong, on what we think that went wrong during this outbreak. So starting only to give a prospection on what we are now in the three countries. In Guinea, Sierra Leone, and Liberia, as you can see in the slide, this is a geographical distribution from WHO, 18th of February. You can see the spots, the red and orange spots are new cases, confirmed cases since a week or 3 weeks. Means that outbreak is ongoing and still in several areas in the three countries. In Liberia is a better situation because the numbers of the new cases are only in Montserrat de Margibi district. If I can explain shortly on MSF activity, we are still present in the three countries. In Liberia, actually less. We are still working in Monrovia with ATU or ATC, Ebola Treatment Center, but very, very few patients. The last 3 days we were at 0. We are much more involved now in outreach activity, in IPC, infection prevention and control, stabilization unit, survival clinic, and helping some hospital for the restoration of services. In Guinea, we are much present with still increasing activity. Only last week another team went to Abofa, that is another district where there were new cases in the last 3 weeks, and we have to engage on rapidly on a response that can take 4 to 6 weeks to manage and to calm down and to go to zero. Still several cases. In Sierra Leone also, presence of project for MSF, and the majority of activity now are really concentrated on outreach and surveillance. So to give you an idea, we are more or less 4,000 staff, international and national staff in the between the three countries right now. To give you only an overview of MSF data, in the slide I only put the patients and their admission in our facilities in the three countries. There are not the patients that were admitted in the transit units and after refer, or on the other country where we intervene. In the meantime, you remember we had also the outbreak in Congo, in DRC Congo. It was not connected to the West Africa country, but it was another outbreak that everybody needed to deal with in the same time. It was in August. We had more or less, since the beginning and up to 2 weeks ago, weeks 7, 8, we had more than 8,000 admissions. Almost 5,000 were confirmed, 2,800 deaths, and more than 2,350 recovered. Now there are very few patients admitted in our structure. The majority are closed or we decrease the number of beds, so we can concentrate in other activities that they are extremely necessary for the outbreak control. And going in another part of the presentation, talking about where we are now, everybody is talking about the second phase. If you consider the first phase was when we were only reactive on ground and only managing to open beds, and we were running behind the cases, and we were not at all able to control whatever. And the pillar were covered. So the second phase now arrived, means that there are not anymore sick people in the community, or there are less, beds are sufficient and even too much in this moment, and there are a second phase where we can really be proactive and control the outbreak. Of course, each country is in a completely different situation, and it's depending the trend of each country, which pillars are not yet covered or where we have gap, and it's depending, as Larry said before, how was the health system situation before and during the outbreak. So for the people that don't have the same language, but talking about Ebola, every organization in fact has perhaps different way to talk about pillars. Ebola pillars are several activities that need to be set up, and every Ebola or even a Marburg, hemorrhagic fever, to be able to control the outbreak and to stop the outbreak. And it's comprehensive. You are talking about bed capacity, isolation, and supportive medical care, including psychological support. It's extremely difficult and traumatizing for a patient and family, when you have the disease in your isolation, but also in the community. Awareness. The anthropological investigation that is so important in this disease. We need to understand the behavior of the community that we are dealing, and we need to understand this because we need to define what are the risks within their behaviors, and we need to define which message and how the message can be spread about the disease, about how to prevent this, how to protect your children, and how to help the entire community to stop this outbreak. Alert, surveillance, and contact tracing. Those activities are the main and most important activity for stopping the outbreak control. You know, when we are talking about contacts and exposure, when we are talking about contact list and number of cases, if we are not able to investigate each case and how many exposed have been provoked by this case, we are not able to control the outbreak. The chain of transmission needs to be controlled, and the 100%, not even one, we can miss. If we miss one, we cannot stop the outbreak. Concerning health access for non-Ebola cases, is part of Ebola pillars in every guideline that we have in the past and now. Maintaining the opening and access for non-Ebola cases is a priority, and with the protection of the health facility itself and the health workers and the patients itself. So those are the pillars, and where we are for the 3 countries in this second phase. In Liberia, there are very few cases. So epidemiologically speaking, they are almost under control. There are really very few cases that they were not in the contact list. So surveillance needs to be strengthened again, but was better than in the other 2 countries. And the major concern really is to stop this outbreak completely, means to have all the contact under list and follow the community involvement that is so important, as Larry was saying before. Health system remain a big concern. I think that Liberia was the country where we saw the majority of the hospitals shutting down. I was there also in December in Monrovia. There were 15 or 18 beds available for hospitalization for a town of 1.3 million inhabitants. People were scared to go to the hospital, and hospital refused or were shut down. So it's a catastrophe that happened not only for Ebola, a number of Ebola cases, but also for the non-Ebola cases. And we are, since some weeks, facing another problem. It's measles cases popping out, and we really need to strengthen the surveillance system and the response very, very fast. We don't want to arrive too late also for measles. This is really important. For Sierra Leone, well, the number of cases are still high, even if they were a good decrease, but they are still high. And we are not under control of the outbreak. The surveillance system for the moment is really, really weak, and there is not even the proportion of cases that are coming from contact list. So we are quite far from trying to reach all the investigation correctly and all the contact tracing. And of course, health system, same problem, big concern, lack of confidence from the community, also from patients to enter in a facility, and now even more with the loss of staff is quite dramatic. And there are a lot of gaps to cover on this, even in the second phase. Measles cases were confirmed also in Sierra Leone since some weeks. Guinea, for the major problem is that the number of cases that there are in Guinea, they are not so high compared to Sierra Leone now, but there are cases and they are spread in different locations and in different districts. We have a big problem to run, and we are still running behind cases in different districts where the Minister of Health still left alone. So there are not enough rapid response teams. We are not under control. This is clear, and the surveillance system is not yet at the top. There is one big also difference between with the other 2 countries in Guinea. We have a big problem with the community. A lot of resistance, denials, still aggressivity. I think that the gap on awareness and community involvement in Guinea is remain and is still very, very huge. Health system also different from the other 2 countries. In fact, there were no hospitals closing down in Guinea, but the frequency was completely going down. Means that the patients, they were not, since Ebola started, they started really to avoid hospitals and facilities and going to traditional either. So it means a lack of confidence, and it's still quite high concern. And yes, in Guinea also, in the second phase, we need to improve and increase the surveillance for the other possible outbreak and communicable disease like measles. So we are in this moment covering gaps in this second phase in all the three countries. We are talking about surveillance, training, outreach activity, community awareness. And for the non-Ebola structure, for the normal hospitals and clinics, we are struggling and trying to cover infection prevention control and trying to resume and enhance health system. This is the actual situation, view from Médecins Sans Frontières, of course. We are still not finished. We are still having heavy projects and heavy involvement in the three countries, and we really think that it will be necessary to continue like this. Now, I'm happy that Larry was really talking about the detection problem and the problem that it took almost 3 months to have the detection of this Ebola outbreak from December. And this is clearly one of the reasons of the first spread. It was not detected for so many weeks, but from our point of view, as Larry said, is also understandable. In a region where Ebola was never been there before, very, very weak system, health system, very remote area at the beginning, and it's quite understandable that this was not recognized faster. In a country where we are working for Ebola in the last years, like Uganda or DRC, it's faster. Now it's faster, but they already know the disease. They set up some surveillance system that is, it was proved that is working. But if it is starting in a remote area, like quite several times in DRC Congo, we will anyway take some weeks before the recognition of the outbreak. But as Larry said, I think that yes, MSF was quite vocal, and not only in August, also before. We have quite a lot of discussion also with the WHO about the fact that we were talking about an unusual situation, an out-of-control situation already in April, and we were not believed. And all the involved actors didn't recognize that this outbreak was dangerous and was out of standard, out of control, and take time. And if you don't recognize this, you will not put the resources that are needed. So the coverage was very, very, very low. And there were the difficulty, especially the first months, to cover all the pillars. There were not a lot of organizations having Ebola experience. This is another reason why this outbreak spread and why out of control. You don't have enough intervenants and you don't have enough actors that have this experience. And also for the pillar of hospital and normal hospital and clinics, this pillar was never included in the national plan of the Ebola task force. And this also provoked a lack of control of hospital setting, where Ebola was transmitted, and this was a big problem. Lesson learned, yes, we know. Now we know that this outbreak spread also because of the mobility of the population, and the world is mondialization and everything. Also in the farthest country, you have now better roads and better capacity to move. So we have to expect this, that the population and the movement, the facility on more and more easiness to move of the population will be one of the issue for outbreak control. And why out of control also? Because the community was not engaged as an active participant on outbreak control. Yes, there was some social mobilization activity done, in some places in a right way and other places less right, to be honest, with not a clear message or difficulties. But Ebola outbreak control, if you don't have the community on your side, you will not control. So I was completely supporting Larry's explanation about we have to need the community with us, otherwise we will not stop it. The community is the first intervenant in such a kind of outbreak, and not only the organization or not only the national task force. This community need to be involved in the right way, in the positive way. If we are able to transmit the information about Ebola, its transmission in a right way, the people will follow and the people will react in the right way. So if we have still resistance, if there are still people that they are hiding themselves, if they are sick or if they are afraid, and if they run away because they don't want to put on stress, on an isolation or on a quarantine, this is logic. We need to have positive way, and we need the community more engaged in this outbreak control. This is one of the main factors, and in this outbreak was quite lacking. And of course, WHO, the coordination, for MSF was extremely difficult to feel this lack of coordination, and was hampering everything. When you don't have coordination, you don't have enough space, enough organization, and you don't have leadership or experienced leadership on this outbreak control, and this was really showing clear for several months, and even now. But this had hampered the control, and this was also one of the reasons why this outbreak was so easily spread and has the door open for going around. Lack of coordination. Coordination and management skills are really a biggest role on such a kind of emergency. And as Larry said, experienced human resources. This is clear. MSF, yes, we have experience in Ebola. We already have the last 20 or more, 20 or 25 years on Ebola transfer and Ebola interventions, but not at such scale and not like this. And we were, even in MSF, completely, and we were struggling to have experienced human resources. It's not a matter of number. We had thousands of doctors, nurses, and logisticians, and Watson asking to be sent in the field, but very, very few had experience. We have a pool. In MSF, we have a pool of experts, Ebola experts that we are maintaining since years, and we have the list of people with name and contacts and everything that can be mobilized in 24 hours in case of an Ebola outbreak or Marburg or the hemorrhagic fever outbreak. But those pools, it was not enough to control, to be able to open activity everywhere where they were needed, and to stop the spread and to control. And this is one of the major factors that impacted also the spread of the outbreak and the out of control. And lastly, concerning preparedness, Larry was talking about WHO and the 5 points that are extremely important. I'm talking about more on the field, on the pragmatic, on the field way in the countries. If you are talking about, for example, the 3 countries now, when the outbreak will be finished, what we have to do after, and try to avoid to have another such a mess. An outbreak can, the vector is there. Ebola virus is in the forest, we know, and what cannot eradicate bats. It is impossible. But how we can prevent next time such an important outbreak, such a spread? And for sure, in those countries now, they know what is Ebola. Now, investigation capacity need to set up in the capital level. Next time that there is an alert, the investigators need to move in the alert area and with grades and more knowledge, they can be able to detect this outbreak before. Laboratory capacity can be at capital but also at regional level. Anyway, in less than 24 hours, we need the results. So laboratory need to remain in the region or in each capital and need to be maintained all over the time. And for sure, surveillance. When we are talking about surveillance, we need, the system didn't work, and this system need to be improved. Case definition need to be clarified for the post-Ebola. When you don't have Ebola, what is the case definition of an hemorrhagic fever? What is the training? Training, we need to train everybody in those countries. Of course, if a fast case starts, I think that it's clear the main issue next time to try to avoid the spread and the out of control, we need to cover all the pillars immediately. So it means we need more actors on ground, more expertise, and we need a better and much better coordination. This is clear. And if there are other countries, because Ebola started in Guinea, it was the first time there, first time in Liberia, first time in Sierra Leone. So means that perhaps Ebola or another disease can come out in another country. So for other countries, preparedness means that they have to recheck their surveillance system. This needs to be investigated and evaluated. What does mean this surveillance system is working or not? This health system is working or not? And it's really important to, in each state, that the surveillance system needs to be checked and reset if something is not going well. Because a fast surveillance, a good surveillance can give a fast detection, and if there is a fast detection and the coverage of pillars, actors, and coordination is good, it's not so difficult, it's quite easy, it's not so difficult to control an outbreak, like was done in the States or in Spain or in Senegal or in Nigeria. And last, I think that I repeat this again, and I think that Larry was much more into detail than me, and I'm very happy. Yes. On the WHO point of view, I think that is of the first importance to discuss and to solve the problem of coordination, leadership, emerging experience, human resources, and management skills. You know, only with surveillance and community engagement, we don't have WHO with management skills, experience, human resources, or leadership capacity and coordination. We will have again another problem, this for sure. And thank you for the attention.
Thank you very much, Rosa. It was an outstanding overview from the ground and what happened, the travails and tribulations that MSF worked through to save lives, which you have done better than anybody else in the world in West Africa. And I think from all of us, thank you and your colleagues for what you have done. And you've described so eloquently what is needed in the future to be able to address and engage in the reform that's required both at a country-state level but also internationally. We have a lot of questions, and I'm going to go through those questions shortly. I will list those questions as they come up. And the first one is from Charles Stack. Charles, I'm going to send this question, Larry, to you. The question from Charles is, Ebola is a Category A bioterrorism agent. Has this outbreak informed our preparedness community about risks from naturally versus human-disseminated agents?
Well, when you mean this community, I'm not sure whether the question is referring to the United States or internationally. From the United States perspective, what Ebola did precipitate is an emergency budget that President Obama had proposed and actually Congress accepted, which has considerable funding for U.S. preparedness at the state and local level. That's very helpful. It's probably not enough. The U.S. has spent a lot of money on security preparedness following SARS, H1N1, and others, but then let it lapse. So, yes, I think this could be helpful in the U.S. having learning the lessons from Ebola, and particularly what happened in Dallas. But we'll have to see if it's sustained. At the international, okay, that's fine. If there are international questions, I can also deal with that. But I think I did in my talk anyway.
Great. So thank you, Larry. This question, Rosa, I'm going to send to you. It comes from Amber Caldwell. Amber also does great work on global surgery for those who want to follow her. So Amber asks this question. She asks, in regards to health system strengthening and encouraging countries to focus on building these systems, how can we influence philanthropy, industry, corporate responsibility to contribute to something that doesn't quite have an immediate return on investment and or has historically been viewed as not sexy? What role, and the second question which I'll take is actually what role can CUGH play in this? So Rosa, that question I'll send to you about philanthropy, industry, corporate responsibility.
For sure, health access is not sexy. This is clear. Having a functional health system is costing to everyone, and is quite expensive, and it's not giving a lot of benefits. I think that we have to push to have a good health system, not only restoration of those countries, but helping all those countries to improve their health system, because we are all co-responsible for a health system and health access in everywhere in the world. We are not anymore disconnected each other in each country. We are responsible for everywhere, as Larry was said. We need to take attention on a global point of view on health access and increasing and improving those health systems. It's not a sexy story, it's clear, but it's a responsibility. It's a mandate, and it's a global responsibility. It's not a business. And when you saw what this can be as an impact for this other country, when one country is not healthy, and you saw this Ebola given a clear example. When one country don't manage and they don't have enough resilience, they are not managing themselves alone, this will impact everybody and all the world. So it's a responsibility for everyone.
Thank you.
But Larry, I think that Larry was better for this question.
That's great. Thank you. And I'll ask just to answer thank you, Rosa. And I'll just respond to Amber's last point about what CUGH can do or has done. So Amber, when this outbreak happened, Ann Kurth, Dr. Kurth from NYU, sent to us the request from Médecins Sans Frontières for their HR request. We went out to our members around the world to seek out their HR needs. Kate Mort from MSF in New York was kind enough to give us their HR requirements, We sent this out to our network of 114 now members and over 10,000 people internationally. Secondly, we've also worked with the Centers for Disease Control, looking for their HR needs. And if you look at our website, you will see the request on there. And you can still contribute to that because, as both Larry and Rosa have said, this need is still ongoing and will go on for a long time. Then what we've done is created a survey with Michelle Barry, another board member from Stanford University. Dr. Barry has worked with us to create a survey. And we sent this out to our members who, quite frankly, the academic community had a variable response. And there are things that were done, and there are things that could have been done, and there are obstacles within the academic community from being able to tap into that extraordinary robust group of capabilities across disciplines that can be really effective at meeting the exact HR needs that both Rosa and Larry mentioned in their comments. So we have put a survey out to identify those obstacles, and we'll work with our members to remove them. Lastly, on the rosters, we've created 2 rosters, as you can see on our site. One roster is for individuals who are interested in working in an acute humanitarian emergency. The other roster is to deal with long-term capacity building. And if you want to join those rosters, please check out our website at CUGH.org and sign up to do so. So the next question that we have is from Mike Cranfield. And Mike says that since many emerging pandemic threats come from wildlife, it seems like preparing for the next outbreak should be a capacity building in the wildlife disease surveillance program, which would be pivotal to the reforming of the global health network. So how do you see this occurring, since most of the focus seems to be with the human problems, and therefore humans act in their own as their own sentinels instead of using wildlife as sentinels? So this is, how do we deal with zoonoses, the involvement of the whole environmental backstory to this? So I'll put it out there. Larry, do you want to take a shot at that? And then Rosa?
I can do it very briefly. Rosa may be more qualified, but I mean, it's very, very clear that if you look at the number of emerging infectious diseases, that the majority of them have zoonotic origins, and one of the great drivers of outbreaks and epidemics is the very intense animal-human interchange we see around the world. This is particularly true in Asia, but it's also true in sub-Saharan Africa. And so, yes, animal health, animal surveillance, and understanding how pathogens appear in animal populations and how they then can be transmitted to human populations are critical. I mean, if you take Ebola as an example, we think we have some ideas about fruit bats and others in terms of the reservoir and the transmission, but we don't have a full understanding. And I think having that full understanding would be very beneficial for prevention, surveillance, and monitoring.
Thank you. And Rosa, did you want to add anything to that at all?
No, I really think that it's really important to try to have more understanding of the virus and the vectors and the reservoir and everything, because it's true that we cannot eradicate this virus. We cannot kill all the bats in the world, and it's not possible, and we destroy the ecosystem. So it's nonsense.
And Mike,
we need to understand better what's happening.
Fantastic. And Mike, I would just draw your attention to the Health Ecosystem and Linkages group at the Wildlife Conservation Society, headed by Dr. Steve Osofsky. They've done fabulous work. And also check out the whole One Health movement. One Health looks at the interface between the environment and health, and they're doing outstanding work to try to address this very issue. CUGH has a partnership with the American Association of Veterinary Medical Colleges to deal with this exact issue. Next question, Rosa. This is going to go to you because this is a very MSF-specific question. Rosa, this comes from Stefan Vinhas. Will MSF be involved in the reconstruction of the health system after the Ebola crisis? The collapse of the health system being a crisis in the crisis, impact on the maternal and child health, other diseases not attended, and the risk of resurgence of endemic Ebola or other diseases. So will MSF be involved in health systems reconstruction?
Well, we were in Guinea and in Sierra Leone before the Ebola. We had a project there, and we will continue to remain in those countries, and we will try to take our best to work with the health system and continue this support, especially now. We are on the. We are talking about the short term. Yes, we remain in those countries for this specific timeline, but for the long term, for sure, also on hospitals management and other medical activity. We have usually in all countries where we are present also preparedness capacity. We are normally and directly with the Minister of Health. So for surveillance, we are normally aware of what's happening, and we can react. We can intervene. So we will continue to remain in those countries. Yes.
Thank you. Larry, this question is for you, and it's from Navindra Prasad. Navindra asks, I think the idea of an emergency fund is a good one. Given WHO's slow bureaucracy, will it be more appropriate for this fund to be managed by civil society so as to ensure a faster response?
Well, there have been a number of very smart people who have suggested to me that the fund should be in different places. I think civil society should be involved, but I don't think that the fund should be managed by them because civil society is just too diverse. You would need maybe one organization like MSF to be the recipient, but I've heard that it should be at the World Bank or other places. It seems to me that we don't want to sidestep the WHO. The WHO have the constitutional mandate, they have the legitimacy, and I want to empower them. I don't want to disempower them. Yes, there have been many deficiencies, and I'm well aware of them. I'm a very close friend of WHO, and close friends sometimes can be very critical, and I have been. But I want to I would like to see this fund go to the WHO, and I think it will. It was originally a WHO independent report recommendation. It's on the WHO Executive Board agenda, and I do think it's going to happen.
Thank you very much, Larry. This next question comes from Dr. Elvira Berakoshia, and Dr. Berakoshia asks the following question. And I don't know if this will go to either of you, Rosa or Larry. Elvira proposes, she said, I would like to propose standard measures be used to assess the epidemic response. Can the speakers propose indicators? Is there a need for an integrated prevention plan for each country to be prepared? So are there any indicators that can be used? And she also mentions there's so many donors and no coordination. The response to the earthquake in Haiti taught us that the pitfalls of too much unsolicited, uncoordinated help. Any plans to help the countries have an effective epidemic control program? I think it's just asking whether or not there's any help to help them to have a more coordinated disaster response mechanism. Rosa, would you like to try that one?
I think that we are really talking about this. When we discussed, or Larry explained the resuming of health system, improving the health system, the surveillance system. Emergency preparedness needs to be present in all the country, and WHO responsibility also to guarantee that everything is set up and everything is moving and need to be moved. All the indicators, everybody knows the indicators. All the medics and the person that they are involved in the surveillance know which are or what are the action and the indicators and the steps and the evaluation means and the checklist that you need to do to be sure that the system and the surveillance good. So it's really a matter of implementation and support that is difficult in this moment. Larry?
Yeah.
No, I think Rosa really hit the nail on the head. I would only mention that the International Health Regulations does specify certain core capacities. Unfortunately, the review committee that reviewed the IHR said that very few countries have them.
And Francis Yang asks us this question, and Larry, I'm going to pitch this one to you. What roles can academic institutions conducting research and providing healthcare in the U.S. be able to assist in the current Ebola outbreak?
Well, I'm not sure I'm the best person to answer, but I can start, and then Rosa and you, Keith, of course, are very expert in this as well. Certainly, research on vaccines, experimental drugs, on effective public health responses. I think the academic community is very good at innovation. It's very good at evaluation, and those are we should really stick with our highest standards. What CUGH has done is it's also mobilized human resources from medical schools and public health schools in the United States and around the world to be deployed in West Africa. And so that's another dimension. But academia is very important. I mean, in order to really get to grips with an effective global health response, you need civil society like MSF, you need international organizations like the WHO, you need academia, and that three-way partnership, I think, could be very, very effective.
Rosa? Well, I'll perhaps add to Larry's comments. As Larry mentioned, CUGH has implemented two things. One is we've created a roster. We've gone to our members, and we've asked our members across a broad range of skill sets whether they'll be able to help in an acute situation, an emergency situation, or to help build long-term capacity. I think one of the great opportunities we have is because we have this incredible pool of assets across skill sets, some of those individuals can be used to help train individuals in these affected countries. If you look at before this catastrophe hit, I think as Rosa mentioned, it was a catastrophe on top of a crisis on a crisis. There's only one doctor for every 50,000 people. But in order to improve well-being, you need proper management, you need a strong public service, you need judicial protection, as Larry has been such an international champion of. You need to be able to have management skills, accounting skills, engineering skills, veterinarian skills. You need a broad range of skill sets. We're trying to mobilize those skill sets that we have and partner responsibly with academic institutions and the public service in the most affected countries to help build their capabilities and their needs as they define them. Because that's not happening right now, and unless it happens, they're not going to build their own domestic capabilities to be able to improve the well-being of their people. So check out our website for those rosters if you'd like to join. This next question is for Rosa. It's for you. It's from Rebecca Chestnut, and Rebecca asks, I recently heard a talk by Sean Healy from Médecins Sans Frontières on the efforts MSF has had to incorporate incident command to improve responses to future emergencies. Rosa, do you have any insights that you can share with us on how this approach will help to improve future emergency responses, or how it might have improved the response to Ebola?
I didn't understand the question. It means that MSF say that we will include?
Rebecca asked, she heard a talk by Sean Healy about to incorporate incident command in the response to the Ebola outbreak and future outbreaks. So she's asking, is there anything you can share with us from MSF on the use of incident command to improve responses to future emergencies?
What is incident command?
I have no idea.
Okay.
So okay, go to the next one.
I cannot answer the question.
Drop you an email about that.
Okay, thank you.
Here's another one from Prakash Nelipalli. Prakash asks, you mentioned population movement as one of the reasons for the spread. Do you have any recommendations on how to overcome this challenge? Rosa?
Yeah, I think that we cannot stop the movement of population. We cannot stop the war because there is an Ebola. From the MSF point of view, the community involvement is the best way to contain an outbreak. Even if you have movement of some people, or some affected or some sick, that can move in another town, even in another country. But if this is followed and this is known, and after there is a health system that can respond, it's not a major problem, and we can deal with this. We cannot stop movement of population, and quarantine are not working. A small example, at the beginning of the second wave of outbreak in Leone, we were working with Ebola and Kemenama districts. It's 3 districts where everything started. And it was quarantine all around. And it didn't work because you cannot manage a quarantine on such a measure. And you cannot manage population that want to move for their life or because they have to work or because they have to go to school or whatever. So movement is not solvable, but follow-up and community involvement can help a lot and can work and always did in the past to control the outbreak.
Thank you. But two more questions.
You cannot stop the flight. No. We had a very big problem in July and August, where several flight companies were stopping to move, and we had problem to join the teams and to increase our capacity also. So this is not an answer. Closing down, prison and quarantine is not an answer for such a problem.
We'll just take a few more questions, and then I'm going to give both Larry and you, Rosa, time to just have a few minutes to wrap up. This question, Larry, is for you. It's from Darren Dukaram. I noted with interest the comment on responding to other outbreaks. Has the presence of malaria been adequately addressed with the primary focus being placed on Ebola?
Well, if I understand the question correctly, is whether some people have suggested to me that since Ebola had such a low burden of disease compared to, say, AIDS, tuberculosis, and malaria, that we should pay less attention to it and that we're paying too much attention. And I'm very opposed to that view. Very opposed. Yes, of course, we need to spend a lot of careful attention on major burdens of disease, including the 3 big infectious diseases as well as non-communicable diseases. But this was a very special case. This was a case of a very fast-moving epidemic in one of the world's poorest regions. And for me, it's unforgivable and unconscionable not to put every possible resource that we can to stop the epidemic. This was, I think, a humanitarian need, but it was also a need of global health security. So that may not have been what this question was really saying. It might just simply be how malaria fits into the global health security landscape, and of course it does, and particularly with drug-resistant forms. And so I could talk a lot about malaria, but I think I'll just leave it at that and focus it on Ebola.
Great. Thanks, Larry. Rosa, this question is to you. It's from Micah Arts, and Micah asks, she asks specifically, in your view, Rosa, what is the role of nutrition in the treatment and recovery of Ebola patients?
It's really important. You know, when you have Ebola, you go very, very fast on a CUGH status. Means you lose energy, you lose weight. It's like you have, you are 20 years old, you have Ebola. It's like you will see your grandparent of 90 years old, completely tired and so on. So nutrition is important, but nutrition is important as an acute needs. You know, if you recover for the survival, it's also not so difficult to recover the energy and the nutritional parts after the disease during the survival time. We are completely, this is in our protocol for all sick people inside isolation and also for the survival. We are plugging out ready-to-use foods with a high nutritional apport. So this is normal. But during hospitalization, the most important vis-a-vis of the nutrition is to have the best way to eat food, because there are people that cannot eat alone, and you need special food to be able to go fast also nutrition, because you cannot stay inside. So yes, it is important, but inside it's difficult, and inside you need to use special diets to cover all the needs and the different needs for each person. After it's more easy. You can take the weight back in some weeks.
And I think it's important for people to know that before the Ebola catastrophe hit West Africa, 38 to 39% of children or more were stunted, which is a big indicator of early deficits, nutritional deficits. The next question, Larry, is going to go to you, and I'm going to have a few words after that. This question from Ishan Desai asks, the role played by universities and academic medical centers in the global response to Ebola. In what ways could this response have been better, and how would you evaluate the response that was made, I gather, here in the United States?
Well, the response by universities and the response by the United States political community was very inadequate. At the university level, I don't think there was enough gearing up for sending human resources to where it was needed. I know CUGH was very helpful and important in that regard, but universities were fearful. Universities also had some really unfortunate policies. Some were quarantining and not allowing people coming back on the campus when they had been in the region. I have friends who, frankly, at Georgetown University weren't able to appear. These, I think, were very unfortunate. And, of course, in the United States, with its discussion of travel bans, with its quarantines, was you just really wanted to say to the country, get a grip, put this in proportion. You've got a couple of cases in the U.S. and tens of thousands of possible cases in the region, and so we badly overreacted as a country. Although we did send the military in, we did sponsor the Security Council resolution. So there's much that the United States can be proud of, but there is much that it can also be ashamed of.
I think it was interesting to look at their response from both European institutions and North American institutions. There was a lot of fear surrounding it, and what we're trying to do is identify what those obstacles are, and we'll put out solutions as to how they can be overcome so that our faculty members who want to be able to contribute can contribute to this. Thanks also for the Department of Defense really did an outstanding job of deploying 3,000 military personnel to West Africa, and I know they worked closely with MSF to try to deal with that. They deserve a huge credit for that deployment in a great time of need. So I think the last question that we'll have here before we have time to wrap up comes from Kelly Lee at Simon Fraser University. Kelly's asking about reform of the WHO, and her bottom line is she asks, Larry, how do you see the fundamental? I'll ask both of you. What do you see as the fundamental reimagining of the WHO? What should it look like in the future? Larry, do you want to start first, and Rosa go second on that?
Well, Kelly Lee is one of the world's experts on this, and Kelly would probably answer her own question a lot better than I can. But I would simply say that it seems to me that WHO has three constitutional functions, and it doesn't always fulfill these functions well. One is the technological function, to be a technical body and to provide technical advice. It's historically done that best of any of its functions, but Ebola showed that even there it was depleted. Secondly is its normative role, creating treaties and the like. It has the IHR and the Framework Convention on Tobacco Control, and that's about it in 60 years. And it needs to do a lot more on its normative side and become which is what its constitution intended it to be. And then third is its operational, its implementational role. I mean, Margaret Chan had said during the outbreak that WHO isn't an implementing agency, but yes, of course, it's not going to play the same role as MSF, but it is intended to be the directing and coordinating global health organization in the world. It hasn't achieved that. So I think those are the three functions we have to empower WHO to do. And I haven't given up on the organization. I think we really need to try to strengthen it in each of those three areas.
Thank you, Larry. Rosa?
Yes, I really think that we don't have many choices. The WHO needs to work better and cannot disappear. The less bureaucracy to solve their governance problem, I think that will be already a good step. And always remembering that for a specific technical or specific problem, you need technicians, experts, and management. And if they really manage to improve on this, it will be already a very, very good step ahead. And keeping aside the ego and having the right person in the right place. And this WHO need to be able to do this, put the right person in the right moment, in the right situation. And they have several very good experts. I didn't saw them in this time.
Thank you, Rosa. And before we wrap up, and Rosa, I'm going to give you the last word since you started second, and Larry, if you close your comments out. I just want to thank everybody who asked questions, who posed questions. I'm sorry we didn't get you. We had an overwhelming number of questions, and we thank you for doing that. And so I'm just going to ask Rosa to take a couple of minutes to any final thoughts, and then Larry, and I'll close it down. Rosa, please go ahead.
Yes, I wanted to stress on the fact that it's not yet finished. I think that every organization now and in this moment need to continue this fight. In the same time, everyone, and probably MSF the first, we really need to have, the obligation to evaluate ourselves and our intervention, to try to take out all the lessons learned, what went well, what we learned, and what we need absolutely to try to avoid next time. I think that everybody needs to start the job, even if the outbreak is not finished. Lesson learned and evaluation, internal and even external evaluation, are really necessary after such an intervention.
Thank you, Rosa. Larry?
I would just pick up on what Rosa said and, of course, agree with her in terms of the importance of evaluation and learning the lessons. One of the things I have proposed, and I think I'll take the opportunity to reassert it, is that I think that there needs to be a very high-level independent inquiry about the performance of the global health system and WHO in particular during this epidemic, what the lessons were learned were, and how we can prevent similar things from happening in the future. I think we need to have Ebola be not just a crisis, not just a tragedy, but a teachable moment. And unless we really have that kind of high-level, thoughtful evaluation and proposals looking back, looking forward, then we will have really made a mistake. I'm very, very convinced that we need to learn from this.
Thank you very much, Larry. And I'd like to also, in particular, thank Karen Lamb here at the Secretariat for her outstanding work in putting this together, and Dalal Najjar, our Director of Operations. They made this happen. I want to particularly, of course, thank our guest, Rosa Cristani. Rosa came from us from Brussels and has been working extraordinarily hard. Rosa, thank you very much for taking the time out of your busy schedule to do that as the Task Force Ebola leader within MSF. And I'd also like to thank our CUGH board member, Professor Larry Gostin, the founding O'Neill Chair in Global Health Law, the faculty director at the O'Neill Institute for National and Global Health Law, and the director at the WHO Collaborating Center on Public Health Law and Human Rights. And to know more about what they're doing, please check out Professor Gostin. He's put out a great book in global health law. And also look at, check out MSF's website, see what they're doing, and support their work. They're saving lives all around the world. Lastly, CUGH is running a global health conference in Boston from March 26 to 28. We're going to have a special Ebola outbreak session and Professor Gostin will be there, along with Dr. Peter Piot, one of the co-founders of the Ebola virus, and a stellar array of speakers. We will also have a wide range of subjects, from how to respond to disasters more effectively to a broad range of other issues. If you'd like to know more about CUGH, check out our website at cugh.org. We will have more webinars, and we look forward to you joining them in the future. Thanks very much for joining us today at the CUGH webinar series on the Ebola outbreak.